us. Again, this is just helping us get a sense of who's in the room and what we should maybe double click on as we move forward. I'll give you a few seconds as people get settled to answer this quick question. And we see even more people joining. Welcome. I'll give people a few more seconds. All right. All right, so it looks like we have a lot of applicants. That's fantastic. Okay, so we'll make sure to guard extra time for that. So I might go a little lighter on some of the deep database information so we can get to the second agenda point for today. So here's the agenda. The first big section, we're going to introduce the database itself. Why is this database available? Who supports it? What is actually in it? Who has access to it right now? How are they using it? And how do I get, as a researcher, how would I get access to the database? And then, of course, I think I'm going to guard even more time than planned for the Accelerated Grant Program. And Dr. Mark Cullen, who leads our Scientific Steering Committee and the Grant Review Committee, will be with us. He's on the line right now, and I will hand the microphone to him. He'll do just a quick overview, and then we're going to open up for Q&A. So you'll see that Q&A function on your screen. Please use it liberally throughout the presentation, and we'll hold plenty of time at the end to get to all those questions. If we don't get to your questions, fear not, we're going to follow up with a recording of this call, of this webinar, as well as updating our FAQ on the website with all answers to any questions that come in. So definitely keep an eye on that. We'll send out a link to that FAQ after the presentation. So let's start with the why. Why is this resource available? Where did it come from? And I think the important place to start here is sort of the mission statement. Almost exactly a year ago, a consortium of partners who are all engaged in the real world data space sought to bring a partnership to bear. They wanted to set up a data resource for non-commercial researchers that would have as much data as possible, as much relevant data as possible for research around COVID-19, particularly on potential mitigation, how maybe clinical care should change, et cetera. And the idea that drove this was that we knew, as we were all participating in this natural experiment of the pandemic, that everyone was interacting with their health systems and generating a lot of data. And that's what we talk about when we talk about real world data, is the data we naturally generate as we interact with our health system or other data systems that are just sort of naturally part of our lives. And the problem with these data systems is they are very siloed. So your pharmacy claims, your interaction with your physician at your primary care appointment versus your ER visit, all of these things are existing in separate systems that often prevent the ability of researchers to interrogate those systems on big scientific questions. This is always a problem. We always knew, I think most people on this call know that this is a huge problem for research and for evidence building around better patient care, better control of costs. However, I think the COVID pandemic provided a real, not only opportunity, but an obligation for everyone to rally together and figure out how could we make this resource available to the non-commercial research community. And I think we all saw this at the beginning of the pandemic. There was a lot of interesting publications coming out, a lot of preprints we were all reading with fascinating science on very small patient populations. So the idea was, how can we build a system that can scale with demand, that can host an enormous amount of data, and this was truly the table stakes, has a robust governance structure that can control access in a way that makes patient advocacy groups, the data source partners, everyone feel comfortable about scaled access to data. So before I go further, I want to talk about who engaged in this conversation a year ago. And we had a number of phenomenal thought leaders who led the way, who are the reason the database is available and looks the way it does and has been successful in the way it has been. And then these were our technology and data partners. And I think actually just going back to the slide, what you'll see is, this was a consortia effort across private sector, public sector, and academia. And I think that continues to be, an amazing rallying point, that all of these people came together, and from brainstorm to fully productionized database, it was about 6 weeks. So it was a very rapid deployment, and it was able to be rapid because we had some phenomenal engagement, not only from our thought leaders, but from these incredibly important partners. So before I get any further, I want to just flag these partners that this would not exist without the partners who jumped in and offered their technology, their data, and the technology partners. I'll talk a little bit about how they fit into this stack, the database stack as we call it. And then the data partners, these are all of the organizations that said that they would engage, given the governance structure, they would engage and make data available to pro bono to the non-commercial research sector. And this is, as I said, this is the stack to give you a sense of what is in the database. So you'll see at the very bottom, the entry level here. So Datavant, and I'll talk a little bit about what we do at Datavant. Datavant onboards data sources and does this tokenized, we deploy a token technology that allows data to be linked across data sources. And we're going to double click on that. We'll dive into that a little bit later, as well as this piece of Mirador analytics, that next stack in this layer in this stack. Mirador is the expert determination service that certifies de-identified data. And again, we'll talk a little bit about that in a minute. Metadata is our very key data operations partner. They manage the data refreshes, the loads, they manage that Snowflake layer that does all of the data warehousing. And we'll talk a little bit about what that means. There's an enormous amount of data available, and this is an incredibly important part. And metadata also manages the provisioning to our researchers, as well as the analytics environment that the researchers leverage for their work. And finally, at the top of the cake, HCCI quarterbacks all of the data governance pieces. And again, I'll have a diagram about that to walk us through what that means. And then we at Datavant help provide technical assistance for the research community. Okay, so what is in the database? Okay, we get the sense of what the framework around it is, but what actually is in the database itself? And the database is over 87 billion records, and it covers over 250 million individuals across all of the data sets. And you'll see at the bottom, there's 55 public data sources. We allow anyone to bring public data in as long as it's made available to the research community, everyone using the database. We also have those 13 major private data sources, and those 13 private data sources are incredibly granular. They are individual level data, albeit de-identified individual level data. And those are refreshed on various cadences, but very regularly compared to other data sources. And obviously this is all made available pro bono at no cost to researchers. These are the data sources available. You'll notice that public data is just listed here. So we didn't list all 55 of the public data sources, but this, just know that, if you go to the Researcher Hub and you click on public data, you'll see all of the various public data sources available. And these are the private data sources. So you'll see we have EMRs, we have health insurance claims, we have consumer data, which is really interesting, especially in a linked way, diabetes-focused data, et cetera. We also have recently made available a Common Data Schema. And I'll talk a little bit about how data is linked together, but I want to first pique your interest in what is available once data is linked. This linked data set covers over 300 million individuals who have either claims or EHR data. And when we deduplicated this and we wanted to see, okay, for the patient journey, we want to see patients who have electronic medical records and claims data available in this. And there's many more data sets available. There's most of the partners who are involved in the database are opting into this Common Data Schema. But just if we're looking at just claims and EHR, how that patient journey snapshot, how many patients do I have who have both data in both places? That was 72 million, over 72 million linked patients. And this is a little out of date, but I wanted to give you a sense a few weeks ago when we tried to say, okay, what do we know about these 72 million patients? Over 4 million now COVID-19 diagnoses. And of those 4 million COVID patients, we've been able to link 150,000 individuals to mortality records. And obviously this vaccine dose count is out of date every day, every hour, but there is a substantial number of vaccine doses recorded in the Common Data Schema as well at this moment. So particularly when we touch on linked data, I want to just stop for a minute and talk about de-identified data. So bear with me. This is a little bit of the more wonky slide, but I think it's incredibly important. And we've gotten a lot of questions about this, particularly with the interest in the grant. So I want to just for a moment pause and talk about de-identified data. Data in the database is de-identified. All of the data is de-identified. That means that the data has dissociated individual markers from health information that can be used for research. And there's two methods of getting a data set to a de-identified state. There's safe harbor, where you remove essentially everything that could identify anyone. And there's expert determination, which sounds technical, but is exactly what it suggests. Expert determination means it's the opinion of an expert in the field who has made a determination based on the information in front of them that scientifically, statistically, the risk is extremely infinitesimally low of re-identification to the patient. So this expert person applies statistical and scientific principles to the data in front of them to quantify risk of re-identification. And they ask for modifications, remediations, redactions to the data set to ensure, to minimize that risk to an extremely, extremely, extremely small, statistically small risk of re-identification. The data in the database is de-identified according to that second method, expert determination. And Mirador is our partner in this. They are an expert determinator. They partner with us to provide the statistical certifications. So just to explain, okay, so we've defined expert determination. We know all the data in the database is de-identified according to expert determination. I want to touch on for a moment Datavant's role here. So Datavant software has been used by each of the participating patient level private data sources. And each of those participating organizations have tokenized their data set, which means at the various data sources behind their firewalls, they have de-identified the data using Datavant software. Before you can say, my data is de-identified, your stat certifier has to say, I've looked at it and there's actually a document, I have statistically certified that this is de-identified. So that has happened either by Mirador or by the private data source's own statistical certification service. They have all said, okay, not only have we run and tokenized the data, which means we've encrypted a patient key, a patient token, where no PII can be, identified by this hash, this patient token. It is removed the information that, is available just looking at the data set that would identify an individual. And we've certified it. We have an expert determination certificate that says this is de-identified. So all of those standalone data sets, when you looked at that list, when I showed the list before, all of those have been de-identified and they have a certificate that says they are de-identified by expert determination. Now, what I just talked about with the common data schema, it means we're linking records together. As we said, we're pulling claims, we're pulling EHR, we're pulling consumer data, we're trying to make a common data schema so you could see more of the patient journey. The problem is, once you start linking data together, you have to recertify the data. So we have gotten recertified for each of those linked data sources, which means our expert determinator has come back in and said, if you pull together this data set, this data set, and this data set, these are the remediations and redactions that have to happen to ensure that this is truly still de-identified. Now, what does this all mean for the researcher? And this is where we come back to all of you. If you've worked with identified data, this is going to be a little bit of a rude awakening. De-identified data does not look like identified data. And you won't have my whole zip code. You will have the first 3 digits. So there are remediations and redactions that have been made because we have to retain the patient privacy as first and foremost. I'm an epidemiologist by training. I have looked at de-identified data. It is tough because it does compromise some of the questions you can ask of the data in terms of granularity, particularly for those of us interested in, geography, et cetera. You can only get to a certain level of granularity. That being said, there's an enormous amount of science coming out of this. And there was this tension that Mark has touched on with us before, that there's a tension between getting more granular and that patient level privacy. So we're walking that line. We have, experts in helping us walk that line, and we want to make sure you have the most data available, but at the same time that the first priority is retaining the patient's privacy. That's all on de-identification. I'm happy to come back to that in the questions, but now that I've kind of gone through that hoop, I want to give you a sense of who is actually using the database. So even though the data is de-identified, who is using the database? How have they used it for their work? And that, I think, comes to that middle part of this slide. We have 210 proposals that have been submitted for review. Over 160 projects are currently in flight. And in those 160 projects, we have over 500 researchers who are on the workbench actively using the data. And these researchers come from all over. We have government, state, local, federal. We have enormous representation from schools of public health, academic medical centers, and we have international researchers from international not-for-profits and academic centers who are interested in the data. I will say as a point here, the data is domestic to the United States. So the data we do not have international data sources at this point. That does not mean there aren't lessons to be learned from the data that can be valid and applied internationally. And this is an example of some of the publications coming out. So this was one, we had an incredibly prolific group, A3AI, who published in partnership, the Economist actually published their work. They worked together with the Economist to create a population level morbidity mortality risk calculator that was published a couple months ago. We have a group that did a technical report, a publication on the effects of school reopening and COVID-19 hospitalizations that got a lot of press. It found its way in the New York Times several times as part of a lot of discussions at the state, local, and federal level around school reopening. The Health Policy Commission has done, in Massachusetts, has done an amazing work on the impact of COVID in Massachusetts, looking at behavioral health in pediatric populations, as well as telehealth usage. We have a recent publication from a group that published on the impacts of access to chronic medications during the pandemic, and another group that published the assessment on the access to medically assisted treatment during the pandemic. So what you can see is there's both examining the direct effects and the direct impacts of the pandemic, as well as the indirect effects. So all of that is fair game. What you'll notice, obviously everything in the COVID-19 database has to be COVID related, so something to keep in mind, but indirect effects are more than welcome, not just the direct impact research. And I would just like to plug, we have another webinar coming up very soon. It's going to focus on the impact of the pandemic on vulnerable populations, particularly looking at stratifying populations by race and ethnicity. In real world data, we're featuring a number of panelists who are going to talk about their work on various data sources in the database. I think this is incredibly, if you are interested in using the data and want to know sort of the ups and downs, the ins and outs, I'm hoping these sort of grand rounds panels of researchers currently using the database can be helpful practically to the research community. We're hoping to build sort of a community of practice around the database. And hopefully researchers can sort of support each other as everyone figures out methods to wrestle with the real world data. So how can you access the database? So here are the practical steps to getting access to the database. I think it's particularly relevant, and I'll try to walk through this super clearly because it was from that initial poll. It seems like a lot of you are thinking about using the database for your work. The first step is registering at the website. So you go to this website, you click that big blue register button, and it will take you to a form that looks like this. And you'll fill out the form. Why is this form important? It's because we have made a commitment to our data source partners, to everyone engaged in the database, that this will be for non-commercial research. So we need to have some gateway, just even to the data dictionaries, that guarantees that this is for non-commercial research. So we monitor that. And please, if you're from a for-profit entity, but you're doing not-for-profit research, please feel free to apply. We might ask a few questions just to clarify, so that when we have that list of people accessing the data dictionaries, we can say, no, we've asked each one, and we're very sure this is for non-commercial purposes. Once you are approved, you'll see, you'll get an email like this. It will inform you that you're approved. It links you to the EULA, the end user license agreement. Please do read that. I know we've flipped through so many of these per day. Please do read that. There's certain commitments, like how it pertains to publication, et cetera, we'd like you to know about. And there are links to the data dictionaries and FAQs within the Researcher Hub. So that's the first point. You don't have access to data yet. You're just registering to see data dictionaries, the Researcher Hub. And this is the Researcher Hub. I know it says database access. You'll be tempted. When I registered as a researcher, was tempted to click on that. You don't have access to data yet. So stick with me for a moment. I'm going to take you on a tour of the knowledge base and the submission hub first. So the knowledge base, the first thing you'll see right at the top is this blue square that says, most viewed articles. I recommend clicking on that data sets available in the research database link first. That will take you to this list. This has a long page linked with all of the data dictionaries and a little snippet, a blurb about the data source. The second thing I would plug for, particularly if you're applying to the grant, I know there's a lot of people here looking at the grant opportunity. Definitely look at the knowledge base. There's a lot of interesting FAQs and obviously the data dictionaries. You'll also see, and I put a red box around it on the screen, the Research Community Forum. We just launched this. It is making the FAQ much more searchable, and you can ask questions on different themes in that Researcher Community Forum. Even if you don't have a question, I recommend going there, because if you are writing a submission, you want to actually access data and you're saying, you know, I think I want to use X, Y, or D data source, but I don't have a sample of data. And this is tricky. I know this, again, I've applied for access to data and done grant submissions before. I have a lot of empathy for this step. We can't give you access to the data yet. So you are writing a submission and you haven't seen the data. And I know that's suboptimal. And we get questions like, can I have just a 10% sample? You can take more information out. We haven't figured out a way to work that into our governance process yet. So right now, we can't give you upfront access to a small sample to sort of play around and see what's there. You don't have access to the data, and we are asking that you submit your research questions before you see the data. I recommend going to the research community forum, asking questions there so that other researchers can see your questions. We are monitoring that. We will try to answer them. So if you have questions about the ins and outs of these data sets, the pros and cons, please reach out there. We'll try to answer as many as we can. We can't go deep. We can't sort of do your 10% sample wrestling with all of them, make all the sort of cross tabs to examine for your question of interest. We can't do that for every group, so we're trying to be as fair as possible. But for general ins and outs of the data sources, please do use that forum. We'll try to be as helpful as possible. And know that the scientific steering committee, and I know Mark might touch on this later, the grant committee is not, they know that you don't have access to the data yet. So know that you're not being judged on that. This is just a snapshot of the forum. If any of you have used Stack Exchange or Stack Overflow, it's modeled after that. So you'll see, you click on these areas, there's some themed areas. There's a theme for each data source. You can ask questions or see the questions and answers in each of those subtopics. The next thing I want to talk about is the actual study submission. So again, in your blue box in the knowledge base, you'll see study submission guidelines. All the information you need is there. The key SparkNotes version of the submission guidelines is that there is a Word document that we ask you to fill out. It's, we hope, one of the lightest touch, the easiest submission forms you will have to deal with for data access in your career. And then you submit it via that submission hub. When you click on that link, it will take you to an Elsevier portal. I'm sure many of us have had to deal with these before, and you submit via the Elsevier portal, just like you would in other instances. You just submit that Word doc via that portal. What happens to your submission once it goes in the portal? The Healthcare Cost Institute quarterbacks the governance piece of this. And again, this was table stakes for this whole database to exist. We needed a way to guarantee that submissions were being vetted, that non-commercial researchers being vetted for scientific rigor and appropriateness. And HCCI ensures that this process happens, that it's well documented. And I won't go over every word on this page, but just to give you a sense that HCCI triages it and gives it to our scientific steering committee. The scientific steering committee is a expert panel. There's a few reviewers, for each various area of expertise: health economics, pharmacoepidemiology, epidemiology. Our chair, Dr. Mark Cullen, make sure that the right experts review each of the submissions. And then we do allow data sources to have a voice at the table too. If there's certain sensitivities they have about use of their data, they can voice those. We try to get this whole process done to get you an answer by 2 to 3 weeks max. So it should be one of the faster processes for data approval as well. So we try to ensure that everything from submission to the answer you get is 2 to 3 weeks. And again, we'll touch on the grant in the next piece. So I'm just talking about if you want access to the data, this is just the process for accessing the data, and we'll touch on the grant in just a moment. Once you have gotten approval for your project, you'll receive an email from HCCI that details that approval, or if there's any caveats, if they need more information, if there's a reviewer who has comments. And you can then, once you have approval, you can name 3 researchers to sit on your piece of the workbench. We keep it to 3 researchers per project because we only have a certain number of seats on the workbench, and we try to get as many projects on the workbench as possible. If there's a problem with that 3 max, definitely reach out to us. We can have a discussion about it, but we really try to keep people to, okay, 3 actual people touching the data at any given time. All data access happens via a secure workspace. You can't just download this data onto your machine. It all happens in this secure Amazon workspace. The AWS workspace has your stat packages there. It has R, it has Python, it has Stata, it has SAS, it has that stat package. You have to set up your tables, your data queries in SQL via Snowflake, and you attach your SQL, your Snowflake data storage to your stat package. And we have whole onboarding guideline, and that's all available in the Knowledge Hub. We will also be doing another upcoming webinar that digs into the step-by-step how to get from point A to point D, C, whatever, wherever you're trying to go. So definitely stay tuned for that. And I would just plug, we try to write efficient SQL. Again, I'm an epidemiologist. I was never taught to write SQL as part of my training. So we recognize this isn't part of a lot of people's area of expertise, and we try to provide as much support as we can. So definitely reach out to us. We're trying to make sure that we can help people write efficient SQL. So now I get to pause. We're going to move on to the Research Accelerator grant opportunity. When we get to questions, all questions are going to be fair game. So we'll touch on questions about the database itself as well as the grant opportunity. Before I hand the microphone to Dr. Mark Cullen, I just want to say, I know one thing at the top of many people's minds is, how do I apply? And we have tried to make this as simple as possible. The form to apply for a grant is in the same form as the study submission form. So if you get to the study submission form, at the bottom is your grant submission form. So it's all in the same form. You submit it via the same hub. So there's no separate process. There's no separate documentation. There's no separate Excel sheet. It's just all there in that Word document. And with that, I'm going to stop my share, and I would love to hand it over to you, Mark, if you want to do a quick intro, and then I can start popcorning some questions we have coming in.
Well, thank you very much, Claire. As always, a remarkably clear and lucid, but very rapid tour through how we got there and what it is we do. I just want to spend a minute talking about how it is that we have funds for the first time in a year to dispense for a small number of people applying to use the Data Hub. Namely, that in the midst of the pandemic, many organizations were looking desperately for access to so-called real-world data, observational data that could be made available in real time and that could be provisioned very efficiently. And one of those onlookers was the Bill and Melinda Gates Foundation. We had other nibbles as well, but Gates came to us and basically said, this is an extraordinary and unique opportunity. Gates, of course, has, as would not surprise any of you, its own areas of particular interest and focus. And so our view of adding to the data provisioning strategy a grant proposal strategy was really to expand and enlarge, but also to focus in a few key areas the work that people are doing. So let me comment just briefly on what those kind of focus areas are, because as separate from the very low bar review that we do of applicants for access to the data, because we really want everyone, every credible group to use it. The bar for the grant application will obviously be substantially higher because we expect a lot of applications. And at the moment, we only have about $1 million to dispense. What are the areas that we are potentially looking for? Well, the easiest way to describe it is that we're interested in focus on health disparities. And that can be in several dimensions. We're very interested, or Gates is extremely interested, in sex and gender related disparities that have occurred. There's been a fair amount of discussion of it, but few very deep dives into why it may be that these disparities have arisen, and they're quite different in different environments. And we certainly welcome applications that have interest in exploring that. We're obviously also interested in the social determinants of health, so racial, ethnic, and occupational and other factors that have enormously contributed to a very heterogeneous outcome to the pandemic in the US context. But in the world of disparities, we are also interested in disparities with our healthcare research environment. And we will, to the extent that we possibly can, reward and privilege grants that are coming from institutions with a typically historically low research profile, so organizations that have not been blessed with large amounts of external funding in the past. And likewise, research groups that we have reason to believe, on the one hand, are extremely competent and have great questions, but on the other hand, have not been the beneficiaries of a lot of largesse. And again, that will be one of the considerations that we will have as we decide how to most effectively dispense the $1 million. But of course, as always, the most important thing is original, important, impactful questions. The whole database was, the whole strategy that we've employed over the past year with our many contributors is to make real world data available very fast on very huge swaths of the population. And we've succeeded in doing it. I think that's how we attracted the Gates interest. Hopefully it's how we've attracted your interest. I'm not sure Claire stressed it, but most of the data sources refresh at a cadence that is better than monthly. Many of them are weekly. Some of them are even daily, which is to say that you will have depending on which part of the population you choose to study, you'll have information on who got vaccines 2 weeks ago or a week ago. You will have information very quickly on responses to same. Those of you who are interested in studying policy can look in very real time at policy changes at the state level, at the national level, and so forth. So it's really an extraordinary opportunity. And with that, I will throw it back to my partner and ask if she's got questions.
We do indeed have questions. So the first one, and I think this may be a question I have to jump in and help with, is data on variant genetics, like so SARS-CoV-2 variant genetic data available for corresponding patients. The bulk of our patient level data is claims and EHR. And I don't believe at this point that we have those codes. I'm going to double check on that. So we will answer this. We'll make sure we update this in the FAQ. We don't have great coverage for labs. So lab data, insofar as it shows up in your EHR, is there. But I'll have to double check on the genetic sequencing and analysis of the SARS-CoV-2. I'm not sure we have good data on that. That being said, there's more data sources joining the database all the time. So we are in conversations with a few data sources who are interested in joining the partnership who may have that data. So that there's a sort of a moving target on that. But yeah, Mark, if you have anything to add on that, I think.
Oh, I do, and I'm going to exploit this question to answer a slightly larger question as well. So, what Claire said is certainly true of what's currently sitting on the platform. But remember that there are many now publicly available variant databases that colleagues around the world have been building, which link in place and time information, not at the granular individual level, but you could know, for example, that in a particular state or region in this particular week, this is the distribution of variants that were extant. To the extent that one wants to bring a public use, non-individual level data set, whether it's genetic or any other type, we are open to that. As Claire mentioned, there are 55 such data sets already on the server, and with the full understanding that everyone else will have access to it as well. And that we'll do is post both the dictionary that goes with it to make the documentation useful and the data set. And we strongly encourage that. We really want people to do it. But I will take a minute to talk about a more perhaps challenging idea, which is we would also love it for an applicant to have a granular set of data that they've been developing, perhaps at their own institution or elsewhere, that they would be willing to, and this means also allowed to, have linked to the larger data set. We, of course, would have to do that work. This is the specialty of Datavant, and it's something that we're well prepared to do. It unfortunately takes a little bit of time and would require analysis from a privacy perspective. So you'll lose something in the new linked data set. Fields will be redacted by design. I'm a researcher. I hate it, but this is the real world, and we need to to be extraordinarily careful about any re-identification risks that we create. As it turns out, in the past year, although this opportunity has existed, very few, if any, users have taken advantage of it because of the time and, frankly, the cost, because this is not a cost that our consortium will bear. But now, if you have such a data set and would like to have it linked to the larger data set, you could apply for the costs within the grant structure. And in fact, we'd be thrilled because we'd really like to test that paradigm.
Yes, I completely second that. Next question, is there a list of data contributors or source data? And obviously this is important when people are designing the research. Please do register at the website. Then you have those data dictionaries. That list I flashed, those blue hyperlinks have the data dictionaries, everything you need, as well as the data contributor name. So definitely check that out. And then upon registration, there is a question that asks about the research plans. And Mark, I think this is certainly one for you. How much detail do you want to see on research plans?
Okay, so this is a two-level answer. So remember, the new application for the grant is actually a compendium of the old application, which literally, although there's a little administrative information, but literally requests, in fact, it allows you no more than 500 words to describe your methods in the access to the data application. In the grant application, we've both provided more space for that and asked a couple of additional questions. And we obviously need enough granularity to judge now with the obviously higher scientific bar. I've put together a review committee of 9, fantastically talented people within individual sort of portions of this spectrum. There'll be 2 reviewers on every grant. And imagine that you are on, because many of you come from the same environment I do, imagine you're on the other side of the equation. What would you want to know about the investigator's idea that would make you sufficiently confident that they can do it? We are interested in high-risk proposals, and the higher the risk, the more you, for example, want to waste some of your few words on what the limits are and where you think you may fail and what you'll do if you fail. We allow up to 2,000 words in the main methods question. Do not feel obligated to use it if it's straightforward and clear what it is you want to do. Feel free to use some of that space to show work you've already done. A table or a figure that illustrates where you are in the universe would be extremely helpful. So you're going to have to use a little bit of your own judgment. We are absolutely not expecting NIH density grants. There's 2 weeks to the deadline. You don't have that much time. We are planning to do our entire review process in 2 weeks with the hope of announcing winners of this process by June 9th or thereabouts, something like that. So be nice to us. Don't give us stuff we don't need. I will have the privilege of reading every single application. So I'm hoping that they are short and to the point.
Perfect. And we have a couple questions. I'm going to package them together about costs incurred and budgets. So the first one was about AWS computing resources. Is it in kind? So metadata provides and partners with AWS to provide the analytics workspace. You do not need to incorporate that into your costs. In the attached submission form, there was a question about the attached submission form. They ask about budget items, and on the web page, it notes that grants cannot be used to cover equipment or faculty salaries. Now, I just updated that FAQ this very morning because we've gotten a lot of questions about that. And I want to hand the microphone to Mark on it. Faculty salaries, what our sort of guiding advice is about salaries as part of the budget.
So let me just again provide a little context. We have hosted several thousand researchers and many hundreds of applications and many, several hundred current users, all on the complete pro bono basis. The investigators work without compensation from us. We work and provide this compute space, the technical support, the data, and so forth without any support for us. And frankly, that includes all the professional staff, including myself. This has been completely pro bono. Obviously, with the advent of the funding, we've moved to a slightly more professionalized status. and we will actually have to compensate reviewers and some of the staff at HCCI who will be doing now work that is exogenous to the original design. But we would very much like institutions that are sufficiently resourced to take advantage of the data to not add fixed costs that they have institutionally to their budget. So that, for example, if you're funded researchers, well-funded researchers really should not be asking for additional funds. This is not an opportunity to give away that kind of funding. I wish it were. I was on the other side most of my career. I understand the need for that, but we strongly discourage that. Individuals applying from institutions that don't enjoy that kind of support should feel free to ask for it if they need it, but it better be justified. And again, I think we in general look more kindly at requests for budget that would include postdoctoral students, fellows, junior, very early faculty who may not be supported, research associates or other technical uses, data management, if you're planning to bring a data set to our server and that kind of thing. Use your judgment.
We have a question about vaccine data. Do you have patient level vaccine administration data, including brand received, dates, location given, etc.? I can jump in and say yes, insofar as it's available in the data sources that we have. So we definitely checked. There is substantial vaccine data, but I think as many people on this call know, a lot of vaccines are happening at mass vaccination sites, and those are not necessarily making it into the EHR and claims data set. So there is some missingness that we need to take into consideration. We don't have an IIS, an immunization information system, piping in data to the database on a de-identified basis. I wish. We do not have that data. We really only have what's available in those real world data sets, and as it's been well documented, there is some missingness there. Mark,
so let me just briefly add to that. So the same is true, of course, of testing data. So testing that people got within a healthcare system, it will be captured in claims, and we will have all of that. Testing that was done in various public sites and privately and so forth, outside the healthcare system at pharmacies and the like, we do not currently have. The good news is we have very granular data on the vaccines that have been given. Those of you who've looked at these things will know that the CPT code book was expanded to include not just vaccine, but specific vaccine, and whether it's your first shot, whether it's your second shot, the manufacturer, and in many cases will have even details, lot number, and things like that. There should now, I haven't looked at the most recent numbers, there should now be some millions of people who've been vaccinated. What you can't do is assume that if you do not have evidence of vaccination, I don't think you can assume in the data that someone's not vaccinated. But if you want to follow cohorts of people that have been vaccinated, I think you can, the data will be granular and very high quality.
We have a question about a list of continuing research questions that are currently being pursued on the database. We're wondering how can I know what's being done so I don't submit a similar project? I might just say one thing about that and then hand it to Mark. We don't currently have a way for you to see everybody else using the database and what they're doing. We have looked into that as something, again, a year retrospective, we're realizing a year in with so many researchers on so many topics, this would be really helpful. However, we have not consented in the end user agreement for your information to be shared. So we keep that very close about privacy. So we have not released that information, and we can't release that information. And I've had extensive conversations with legal teams about this. We don't, even though it would be beneficial to know about novel topics. However, we are entering a partnership with Exaptive to put together what we call Cognitive City. That'll be a mapping of research projects. It will be an opt-in, so you'll consent into being mapped. So this would be my plug. Look for this in an upcoming email from all of us. We would love people to opt in, particularly if you are pursuing research with or without the grant on the database itself. And a reminder, you do not need a grant to use the database. It is free access insofar as you're able to use it. So please know that you're in the running to use the database regardless of grant. And everyone using the database, we would love to map for exactly this reason, but also to create connections across across teams. If you may want to know, I mean, we have certain institutions who have many different research groups from the same institution working on the database, but we don't think they know that they're each other, that they're working. So there's certain things just not only for that particular use case, but for others, we'd love to be able to map everyone. So a plug, please opt in when you see that option in the near future. But Mark, anything about novel, perhaps novel projects, should they be concerned about it?
Right. So I want to do two things. One is I want to underscore, in case it's been less than clear in what Claire has been saying, that we hope all of you who apply for grant funding recognize that it's the little short application in front for the data access that is actually the biggest grant we're going to give you. It's great in two ways. One is that you're almost certain to get it. If it's, I mean, again, we do not apply a super high bar of creativity, originality, and so forth to giving people access to the data. So think about that as the real plug. The data are fantastic, and in any other setting, in the commercial world, you'd pay very dearly for data of this scope and quality. I mean, very dearly, many orders of magnitude more than you would possibly get from a grant. So that's the real pearl that's there. The grant is an add-on, and a few of you will, of course, get that. The second point I want to make about originality and so forth is for those of you who are not doing it, I spend a few minutes every morning or every few mornings going through the bio and med archive preprints that are thrown up, and look at JAMA, New England Journal, Lancet, and others that have dedicated lots of online space to early publication. Know the literature. I mean, it really will behoove you to know what's being presented. You don't have to know what people have in the works to have a pretty clear idea of what areas are being pretty well represented and what areas are being less so. And as we look at innovation, we will not compare what your idea is against someone who may, a month ago have had a great similar idea if they haven't produced it yet. I mean, if there's nothing out there in the public domain that we can see in terms of results, we will treat you as first in show. So worry about what's out there and what people have already published, or pre-published, but don't worry that much about what might be quietly in the pipeline. I don't think it's that important.
Perfect. And we had a few more questions about budget. I would go back to just what Mark said. Use your best judgment. RA budgets are allowed. There's not any firm rules. I know in the absence of firm rules, we feel like we might be missing something, but again, just use your best judgment. There's a question about genomic data. Is genomic data available? And there's an omics data set available. Now that does not have extensive patient genomic data. It has genomics, I believe, on certain bacterial resistance data. So I would definitely look at the data dictionary for that omics data set. It isn't just like everybody's 23andMe. So I don't want people to get the feeling that there's a big genetic data set there. So the genetic data is pretty limited. Again, back to what Mark said before, we'd love to see proposals, and we can work with the stat certifier. If you want to have a data set to bring to bear, definitely put that in your application, and we look forward to talking with you about it. Anything else to add on genomic data or budgets, Mark, before I move on?
Right. Well, so let me just make a comment about genomic data. So unlike the now publicly available and quite remarkable data sets looking at variation and the distribution of variants, so we're talking about viral genomics. Human genomics is a whole nother thing. And although, as many of you are aware, genomics data sets themselves, without metadata attached to them, other than kind of the very small amounts of metadata that, for example, are in the UK Biobank, genomics data sets themselves are effectively not linkable under current rules around the world with the kind of data that we've got, because they would become immediately re-identified, and I think that's not likely to happen. So in terms of studying human genetics as it may relate to risk of disease or risk of severity of disease, mortality, and the likes, I think that's probably an area that this database will not be ideal for exploring. to be totally candid, it's also so far from likely to explain the kind of health disparities that we're worried about that we would probably look askance at such an application on its own scientific grounds. But the short answer is we don't have individual level human genomic data.
There's a question about how our data sets linked and that it wasn't super clear. And I will touch on it, but the best place to get an in-depth answer is in the Knowledge Hub. So there is, if you look for, you can keyword search token or linked data in the Knowledge Hub, there's extensive documentation written on it. But just to give a little more of a snapshot, the individuals have been tokenized, meaning that there is an encrypted patient key for each individual in the separate databases. Now, I have a different patient key in my EHR, in my claims, in my consumer data. So if it all just happened to be in the same, if you have those 3 linked data sources or 3 unlinked data sources, and I happen to be in every one, you can't figure that out from my token. The token is hashed, encrypted. You can't just look at it and figure out a way to match it yourself. Now, in the Common Data Schema, which is the separate data source, and you can't have access to all the unlinked data and the Common Data Schema. So you have to choose carefully. Again, that documentation's in the Knowledge Hub. If you opt for the Common Data Schema, we have made those tokens linkable across data sets. So you can match tokens across. And we've done that because the stats certification service has come in and said, if you have, my 2 wearables and my claims and my EHR, even if you had that all together, we've redacted and remediated in such a way that you can't figure out that it's Claire. You just know that this is the same patient across the data sources. So that is sort of my snapshot response for that question. But Mark, I don't know if you want to add any more granular detail on the link.
No, I'll maybe just quickly reframe it another way, without direct, reference to the great technology that Datavant brings to the party. Imagine every time a data set is acquired by by one of the data contributors, they strip off some of the information from that for any use of those data. And they strip it off into these things called tokens, which have that information. And so every data set in there has a bunch of fields you'll never see that have been stripped off and turned into tokens. And that the availability of the tokens, unlike a data set that's really been killed by stripping them off and throwing them away, these data sets are still alive and they can be linked to further data sets because of the existence of these tokens. You don't see, the investigators never see the tokens. These are for data managers to do linkage. But as Claire said, the downside is because of privacy concerns, every time 2 data sets are linked, some data needs to be redacted usually to make the new data set, which is richer, not so rich that a reasonably sophisticated hacker group could re-identify it. Remember, re-identification is a quantitative thing, and there's no such thing as zero risk of re-identification, but our expert judgment brings that risk down to an extremely low level such that you don't have to worry about it. Most of these proposals would be IRB exempt at your institutions because you're not dealing with identifiable data.
There's a question about how do we know whether variables are COVID related, COVID diagnosis, pre-COVID, during COVID, et cetera. And I can offer this up in a quick, and then Mark, I toss it to you. My initial reaction, and because Datavant is involved with supporting as part of the FDA's therapeutics accelerator, supporting a PI looking at this. So we've tried to wrestle with these questions. It's definitely real world data. So you'll have different data points in these data sets for the same person. And if it's in the same file, you should be able to know, okay, but if it's in this single data set, if I'm just looking at Symphony, here are these snapshots of this person. You have diagnosis. So there's a COVID ICD code. You'll be able to evaluate based on the codes available in the data set, whether COVID diagnosis has happened. There's a certain amount of inference, and I know there's certain groups who are working on inference and inferring certain connections, and they are building that out in their methods. And to give you an example, we have mortality data available. And as an epidemiologist, obviously health outcomes research, mortality is a really essential health outcome. That mortality data set is apart from the usual health data sets that we wrestle with. And oftentimes death is not captured in those traditional data sets. So you may see patient A had a COVID diagnosis at this date. And if you're using the linked data, there's a mortality record for that patient. You don't have cause of death on that mortality record. There are certain groups that are trying to infer, okay, based on what we saw, age of patient, et cetera, can we infer a COVID death on this record? Now, so I would say that there's a certain amount that's going to be just available in the data to wrestle with, and there's a certain amount that research groups are going to have to decide in their methodologies, how are we thinking about this patient journey? Because again, real world data is happening. It's not a perfect clinical trial where we're following every step of the way. Obviously, this is just the patient's interaction with their real world data sources. So I'll stop there. Mark, did I?
No, you did it. You did a great job, and I'm really glad you brought up the death example because it is the most persistent, relatively serious question. I mean, we don't have date of death, we don't have cause of death, we have year of death, which means if someone died in 2020 and had COVID, we have, they have to have been alive when they were diagnosed. So we know the order of the events. We don't know the timing of the events or exact relationship, and someone could have been discharged from hospital and be hit by a bus, and you won't know that from the data. Fortunately, any inferences about diagnosis, which was an incredible crisis last spring, because so many people were going to into healthcare and getting treated for huge respiratory and obviously inflammatory respiratory illnesses. Some of them died without a diagnosis of COVID, but that stopped being a problem by last summer. And certainly when you use the data from the surge in the fall and winter, pretty much everyone that had COVID was diagnosed as having COVID. There wasn't much difficulty in getting testing and so forth. You should have no difficulty in claims or EHR data in figuring out, and there you will have very detailed information about when the diagnosis was made and what followed.
Fantastic. We have room for one more. I'll sneak one in. I see that we had some questions about current groups that are already using the database. They want to apply for the grant. I know Alex wrote a great response in terms of just process. You just have to submit a form. So you have to go back to the submission form and submit with that grant detail. But Mark, is there anything you want to say to groups that are already using the database that may want to apply for the grant?
Right. So point number one, we love it. Please apply, especially if you have a new direction or something that you could not do but for the additional resources. In fact, that's the standard we'll likely apply, which is, do the resources make a difference in your work? We'll apply that to new users and old users, but that for old users, we don't just say, oh, great, now we've done all this work, we'd like to get $100,000. That will not be rewarded. There'll need to be some evidence of further use. Not to discourage that, but I do want to point out we will not be advantaging old users. So old users do have a natural advantage. They've seen the data, they've done work, they might have work in progress, they might have beautiful figures and tables to throw into their application, which is great, I love it. But we will not be, let's put it the other way, punishing new users and disadvantaging them because they don't have that intimate relationship now with the data. So apply new for a new piece of the idea, make it justified and relevant, and we'd love to see it.
Perfect. Well, thank you all. And as Alex pointed out in the Q&A, please do email us for more questions. We'll update the FAQ. We want to make sure any question that's asked, we're trying to update the FAQ to make sure everybody has the same information. Keep an eye on the FAQ. It's changing daily. And yes, good luck with the submissions. Thank you so much. Thank you, Mark.
Goodbye all. Thanks for your participation.
Cheers.